We're going to spend this chapter talking about immune-mediated diseases. And the first thing we're going to discuss is the evaluation of your suspicions of immune deficiencies. Some of the things that you're going to look for obviously will be in the history. Look for increased frequency of infections. Also look for unusual severity of infections, and look for opportunistic infections, unusual organisms, prolonged course of infections. Look for recurrent sinusitis or recurrent pneumonias. That's very important to see that you'll see in children. If children are sick often, they may have failure to thrive. Patients who are immune compromised many times will have thrush or diarrhea. Now, children get some of these infections quite frequently. For example, they might get thrush, but if you see recurrent episodes of thrush, that makes you a little bit more suspicious. Also, look for other associated conditions like skin problems or autoimmune diseases, which might put a patient at risk for some immune-mediated diseases. A family history of immunodeficiencies is also important. Basic labs, a CBC. Also look for your differential, because the differential will help you with absolute neutrophil counts and absolute lymphocyte counts that we'll discuss in a few minutes. A smear to see what the cells actually look like, and a SED rate, a non-specific test, but it's helpful if it's elevated. The normal absolute lymphocyte count will let you pretty much eliminate T-cell defects. The way that you calculate absolute neutrophil counts or absolute lymphocyte counts is you take the total white blood cell count and multiply it by the percentage of the lymphocytes, and that gives you the absolute lymphocyte count. If you multiply it by the neutrophil percentage, that gives you the absolute neutrophil count. If you have a normal absolute neutrophil count, then you've pretty much eliminated congenital or acquired neutropenia. And typically, neutrophil count should be greater than 500. That's probably your lower limit before you start worrying about infections. If you have a normal platelet count, you pretty much have eliminated Wiskott-Aldrich. A very basic test is the CBC. Gives you a lot of information. The peripheral smear, look for Howell-Jolly bodies. This will suggest asplenia. And a normal SED rate will exclude chronic diseases or fungal infections. So those are basic preliminary tests to start with. Other screening tests depend on your suspicion of what disease. So for B-cell deficiency, a screening test would be quantitative immunoglobulins. When you order quantitative immunoglobulins, order all the subsets, because you might have an overall normal amount of immunoglobulins, but you may have a deficiency in one of the subsets. So always order the subsets. And you can always order antibody titers. For T-cell deficiency, you can order the absolute lymphocyte count off your CBC, and you can do skin testing for delayed hypersensitivity. With phagocytic deficiencies, you can order an absolute neutrophil count from your CBC, and you can also order a more specialized test, which is a neutrophil respiratory burst. And for complement deficiency, the best test is the CH50. Some of the patterns of immune deficiency, look for problems with antibody, phagocytic, or complement. Look for recurrent infections with encapsulated organisms. So that would be, for example, like strep or H. flu. Look for the encapsulated organisms. So when you're reading the test question, if they're describing these recurrent infections, you should be thinking along the lines of deficiencies with either antibody, phagocytes, or complement. For T-cell function, again, the opportunistic infections early in life with a subsequent failure to thrive will make you suspicious. Killing defects, look for recurrent staphylococcal abscesses or recurrent gram-negative infections will make you suspicious for specific killing defects.